Hi, thank you for joining us, and welcome to MLI's Community Collective, harnessing the power of the community to battle obesity. This activity is supported by an educational grant from Lilly, and this is the second of a three-part series, and this one is on practical applications of new and emerging data. If you missed part one, just use the same link that you used tonight to join us, and you'll be able to watch the recording for activity one from that screen. And don't worry if your colleagues weren't able to join us tonight, this information will be available to them at their convenience, and we'll put that registration link in the chat so they can view it prior to our third event, which is an in-person live next week, Tuesday, May 21st at the Belga Cafe, the Betsy Rooftop Gin Garden in our beautiful downtown Washington, D.C. Our hope is that after listening to both of these presentations, you'll bring your challenging cases and your practical questions, and don't worry, you don't have to write anything down. But this is an exclusive event for you so that you can meet your colleagues, discuss some of these challenging cases and practical questions that you have so that you're more comfortable treating your patients who face the challenges and comorbidities that may come along with overweight and obesity. So tell your friends and make it a date. Now, before we start, we'd like to start with just a couple of pre-test questions. Please look at your screen and answer just once. Okay, pre-test question number one. Mr. J is a 50-year-old Caucasian patient with a BMI of 34, which is categorized as class 1 obesity. If his waist circumference is 122 centimeters or 48 inches, what is his disease risk relative to normal weight and waist circumference? Okay, pre-test question number two. A second generation AOM was initiated in your patient 2 weeks ago. They report that they've been experiencing some GI issues. Which of the following is the best way to manage these common side effects? Great, thank you. And pre-test question number three. To facilitate shared decision-making, what counseling and educational points would you provide a patient regarding a second-generation AOM, allowing them to make an informed decision about their therapy? Okay. Thanks so much. We will be monitoring the chat, so please feel free to answer your questions there. And I'd like to thank everyone who's joining us on YouTube. Now, with all that said, it is my great pleasure to introduce one of the leading experts in the field of obesity, Dr. Scott Kahan, Director of the National Center for Weight and Wellness. Dr. Kahan, thank you so much for joining us, and I'd like to turn this activity over to you.
Thank you very much, Kristen, for joining us. Let me share my screen here with the slide set, and then we'll dive right back in. Okay. All right. So we're going to continue our discussion from last week, focusing much more on the newer generation medications today. And we already reviewed the learning objectives. And we already had the pretest questions, so I'll skip by those. And here's a case study that we're going to use a little bit for our discussion tonight. So this is Mr. J. He presents in the clinic for a checkup. He complains of being more lethargic than usual. You can see his medical history here: obesity, type 2 diabetes, hypertension, dyslipidemia, sleep apnea, fatty liver, gout, and osteoarthritis. Probably pretty similar to a lot of patients that we see, and of course, often so many of these metabolic conditions go together. And then you can see here his medications, notably the metformin, amlodipine, empagliflozin, glimepiride, rosuvastatin, allopurinol, and then losartan hydrochlorothiazide. And here's a little bit more on his lab situation. So glucose is 190, A1C 8.1, and that's already on 3 medications for diabetes. Hypertension, also on 3 medications and still hard to control, 150/90. Dyslipidemia, not quite as out of control as the first 2, but still you see his triglycerides are quite high, HDL is low, LDL, given that he has diabetes, that's still quite a bit over the target range. And you see weight there, and BMI, waist circumference is 48, and then he's got at minimum clear fatty liver disease. Additionally, as mentioned, the obstructive sleep apnea, osteoarthritis, and acanthosis nigricans. So this is the patient we'll refer to several times. I pointed out the importance of using waist circumference to add more data than what we get from BMI alone. So if we look at Mr. J here, with his weight and height, his BMI is in the obesity class 1, and the waist circumference being so high further shows us that his risk is even higher than it would be for carrying around the weight that he is. So this would be considered a very high risk patient for cardiovascular disease development. And so that gets to one of the pretest questions. So let's do that again. Mr. J is a 50-year-old Caucasian patient with a BMI of 34, waist circumference 48 inches. What's his disease risk relative to normal weight and waist circumference? Increased, high, very high, or extremely high? Let's see what you think this time. So it would be very high risk given the high waist circumference. I realize they all sort of sound similar, but again, the important point here is that he's at high risk because he's carrying around a lot of weight. He's at even higher risk because a lot of that weight is centrally located. And so we're going to keep going. Now, the other thing we talked about last time is that while carrying weight, especially in the central part of our bodies, has a lot of risks associated with it, modest weight loss usually improves a number of those risks, and a little bit more than modest weight loss usually helps even more. So you see here with the comorbidities that this case example has, the top 7 there, as little as 3 to 5% weight loss improves many of those. And once we get to 10%, let alone 15% or more weight loss, we tend to see even larger improvements, particularly in the hypertension, the dyslipidemia, the hyperglycemia, and diabetes. With sleep apnea and fatty liver disease, usually you need 10% or more. And then you can see similarly with some of the other conditions listed here. So we're really trying to get to a meaningful amount of weight loss for this patient, hopefully then improving a range of the health problems that he has to deal with. Now, we mentioned last week the benefits of a number of medications that we've had for a number of years for weight loss, and we can get to modest weight loss with a number of those medications, sometimes even a little bit more. With the newest medications, we usually are able to get to still more weight loss. So semaglutide, the STEP trials showed the effectiveness for semaglutide in obesity. And you can see here that across those trials, we have really nice weight loss, usually in the 15% weight loss range. We always get less weight loss in patients with diabetes, but usually right around that 15% weight loss range in semaglutide compared with placebo. And again, most patients are losing at least 5% of their body weight compared with people who just get a placebo. You have some that are losing 5%, but it's typically a minority of people. Then in the SURMOUNT trials, which were the clinical trials for the tirzepatide program for obesity, we see even better outcomes. So often at least 15%, even in the 20% range at the mid and higher doses for tirzepatide for obesity. Again, a little bit less weight loss, quite a bit less with diabetes, which is what's expected. And almost everyone is losing at least 5% body weight compared to relatively few in the placebo group. So we can expect pretty darn good outcomes when treating people with these newer generation medications, particularly patients like Mr. J that I just showed you. Here's just another way of looking at that data. So when we look across a year in patients taking semaglutide, again, very nice weight loss in the range of 15% or so at a year compared to almost no weight loss with placebo. And with tirzepatide, even more. At the mid and high doses, we're getting 20% weight loss at around a year compared to next to nothing for placebo. Now, this is in people with obesity, but not diabetes. When we look at the diabetes population, first and foremost, as I mentioned, almost always patients with diabetes will lose less, and the clinical trials that study patients with diabetes will show less weight loss. That said, we still get good weight loss with these medications in the diabetes population. Now, first, what I'm showing you here is treatment with semaglutide in the SUSTAIN trials, which were specifically for diabetes treatment. So these weren't explicitly weight loss trials. And yet with this medication, you get a nice bit of weight loss, 4, 5, 6% weight loss, 6.5% weight loss. And again, this is in the diabetes dose of the medication and in patients who aren't necessarily getting intensive counseling for weight loss or the like. Still, a lot of weight loss compared with placebo. So that's nice to see. In the tirzepatide trials, the SURPASS trials, again, this is patients with type 2 diabetes. We see weight loss with the medication, but these are not weight loss trials. They're not getting extensive counseling and motivation for weight loss and such. They're doing what they can. And we see even more weight loss compared with the semaglutide groups. So 6, 7, 8%, 9, 11%, 11.5% weight loss in people who are just taking this medication, tirzepatide, for diabetes, and they get the nice benefit of the weight loss as well. When we look at trials, in this case, trials of tirzepatide for people with both obesity and type 2 diabetes, that's where we see the most weight loss, because not only are they getting the medication, but they're also in a trial that's explicitly geared toward helping people to lose weight. And so at both the mid and higher dose, we see 15% or more weight loss, 16% at the high dose, almost 15% at the mid dose, compared to very little with placebo. When we look at A1C improvements, as you would expect, in the placebo group, almost nothing. And in the tirzepatide groups, really, really impressive improvements in A1C, going from 8 to about 5.5, so or 5 3/4, which is to say, almost everyone is getting to goal, and on average, people are actually getting not only out of the diabetes range, but even potentially out of the pre-diabetes range. It's really very impressive what we see here. We don't see quite as impressive with the semaglutide trials, but still, it's impressive there as well. And then when we look beyond weight loss, I just mentioned plenty on the glycemic control, so we'll skip that. We see very nice improvements in lipid levels with tirzepatide as well as semaglutide here, and that's triglycerides, total cholesterol, good and bad cholesterol as well. So that's expected in part from the weight loss and in part from the metabolic effects of the medications. And then when we look at hepatic outcomes, on the left here, we have semaglutide in a phase 2 trial for biopsy-confirmed NASH. And so we see resolution of NASH with no worsening of liver fibrosis in a significant portion of people particularly at the slightly higher doses of semaglutide, but across all the doses that were studied, and only a very small number of people who took placebo had a similar resolution. In the tirzepatide trial, which was a sub-study of the SURPASS-3 trial, when we look at relative change of liver fat content, very nice improvements across the tirzepatide groups, with only a very small improvement in the insulin treated group. And then perhaps most exciting is we see improvements in long-term cardiovascular risks. With semaglutide, there has recently been an explicitly published study for cardiovascular outcome improvement. We see 20 to even 25% improvement in hazard ratio compared with placebo for long-term cardiovascular outcomes. That study is ongoing right now for tirzepatide. We'll see that in the near future. We do have, though, a large meta-analysis of over 7,000 patients across other trials. And when we look pooled together at risk of MACE outcomes, pretty similar, about a 20% decrease in hazard ratio. So that's not a full cardiovascular outcome trial. We expect that in the near future. We're still, I think, a couple years away from that being published. But everything we know about how these medications work suggests that we should have at least as impressive an outcome once that medication trial finalizes. So very exciting here. I would argue that even if we didn't see an improvement in cardiovascular outcomes, if we just saw no worsening, that would be very positive. But that we're seeing improvements here is really, really impressive and very important. And as such, the FDA, if you haven't already heard, added a second indication for semaglutide. So in people who have obesity and established cardiovascular disease, this medication may further be approved. It's not approved to prevent cardiovascular disease. We don't actually have data saying that this medication will prevent cardiovascular disease from coming on. But in people who have known cardiovascular disease, the medication has been shown to decrease the risk of adverse cardiovascular events. Now, that said, of course, there's risks with these medications, and I want to go through all of them. So for one, the contraindications for both of them are a personal or family history of medullary thyroid carcinoma or MEN syndrome type 2, and of course, a known hypersensitivity to tirzepatide or semaglutide or any of the excipients. Now, neither of these have been studied in patients with a history of pancreatitis. We know that the GLP-1 medications as a class do increase the risk of pancreatitis. It's not a large increase, but it's a real increase. We need to be mindful of that. In general, we avoid using the medication in people with a history of pancreatitis. And if someone develops pancreatitis on it, of course, we stop the medication. It's not indicated. It hasn't been fully studied, neither of them, in patients with type 1 diabetes. Some other warnings and precautions. So acute gallbladder disease is possible, and of course, pancreatitis. A significant portion of the cases of pancreatitis occur secondary to gallstones, but there's other cases that there doesn't seem to be evidence of gallstones, so there may be a direct toxic effect on the pancreas. So we need to be mindful of those. Hypoglycemia is possible. We only tend to see severe hypoglycemia when patients are also on insulin secretagogues like TZDs or insulin itself. So if a patient is on I'm sorry, not TZDs, I meant sulfonylureas. If a patient is on sulfonylurea or insulin, almost always we'll get them off of it when we start these medications, or if not, we'll significantly lower the doses and we'll monitor them very closely, and likely we'll be able to get them off completely pretty soon. But you need to be mindful there. Hypoglycemia is possible even in people without insulin or sulfonylurea, but it's really not very common, and severe hypoglycemia is particularly uncommon if people aren't on insulin or a sulfonylurea. Hypersensitivity reactions, of course, can happen. acute kidney injury is one of the warnings. I've never seen that happen. And in fact, we believe that there is a kidney protective effect across the class of GLP-1 medications. Severe gastrointestinal disease is possible, and you can get a lot of gastrointestinal side effects for some of the patients. I'm going to talk more about that shortly. And then diabetic retinopathy complications in patients with a history of diabetic retinopathy. We have this slide here. It's similar to what I showed you last week with the older medications. I covered most of these, the serious risks here and contraindications, but I kept it in here just so that you have it in a single place, because you can print this out for yourself later. But I'm going to move on because I want to talk specifically about the most common side effects to be mindful of. And here they are. By far and away, the most common is nausea. More than 20% of people will get nausea. Most of the time, it's not very significant, but sometimes it is. In the range of 10% of people will get vomiting, 15% or so diarrhea, at least 5 to 7% will get constipation. I find quite more than that, and at least 6 to 9% dyspepsia. I find quite a bit more than that as well. But nonetheless, in most cases, they tend to be mild. And in most cases, we're usually able to get around them. And I'm going to give you some tips on that in a moment. Another common side effect that's not listed here is fatigue. So that can certainly happen. Sometimes a lot of weight loss leads to fatigue, but these medications directly can cause the effect of fatigue. Similar to what I mentioned before, in most cases, it's mild. It's not a big deal, but sometimes it is. So we want to be mindful of that. In most cases of patients that get nausea, the nausea resolves, sometimes over days or weeks, sometimes over months. But as you can see here in a trial of semaglutide, whereas the nausea increased very significantly in the first few weeks, it then decreased over time. So it's not going to happen with everybody. Some people, you're going to have to stop the medication because of severe nausea. But in most people, it'll either resolve on its own, or we can help resolve it on its own with treatment for the nausea. Here's some other studies with, particularly with tirzepatide. It's a similar picture. A good number of patients will report nausea at all the doses in the first few weeks, in the first couple of months, but most often that will either resolve or significantly improve over the next several weeks to months thereafter. So most of the time, we're able to continue using the medication, even in people that get a lot of initial nausea. Some basic tips for people that get the gastrointestinal side effects, whether nausea or the other gastrointestinal side effects. Eating slower really can help. So suggesting to patients to try to do that is useful. Smaller portions is especially important. Because of the delayed gastric emptying that occurs as a side effect of this medication, of either of these medications, when there's more food that just sits around in the stomach and the intestines, that can precipitate some of these side effects. So just being really mindful and intentional to have smaller portions, perhaps having smaller, more frequent meals throughout the day can be helpful. Avoid skipping meals. Minimize very greasy foods and high-fat foods. Similar strategies to behavioral tips for minimizing reflux. Obviously, if there are certain foods that tend to bother the patient, avoid those offending foods, and then refrain from lying down after meals. Now, in addition to that, there are some other really helpful strategies that we should consider in our prescribing. So as they're escalating the dose, we might slow that escalation, perhaps really slow it down if they're having these side effects, rather than continuing to increase the dose every month. And in some cases, we suspend the medication temporarily and then restart it. In other cases, we even lower the dose. Rather than just holding but not going up, we'll lower the dose a bit, backtrack a bit, get them to tolerate it, and then very slowly go back up. And then we can consider some other things. Of course, as with any patient, that comes in with a condition or a complaint, we want to consider a differential diagnosis that might rule out other conditions that may be responsible. Because if a patient has nausea, it's not necessarily always the GLP-1. We want to make sure the patient understands the lifestyle changes that are going to be helpful for them both to lose weight and to moderate side effects from the medications, and do the best you can to support the patient to comply with those changes. Um, and then, if needed, we can start measures specifically to address the troublesome side effects. So that can include an antiemetic or a prokinetic. It can include antidiarrheals. It can include stool softeners. And in most cases, people are able to tolerate the medications using these various strategies. So this is the dose escalation, as mentioned. So for semaglutide, it's a monthly escalation starting with 0.25 milligrams, then zero point 0.5, then 1 milligram for another month, then 1.7 for another month, and then 2.4 thereafter. Technically, the 1.7 and the 2.4 milligram doses are the resting doses here. And the insurance companies have you push all the way up to those higher doses. Whenever you can slow that down, if a patient is having side effects, that's hopefully going to be valuable. But there are going to be people that just can't tolerate these higher doses, unfortunately, and may have to stop the medication if you're unable to get the insurance to allow longer times at these lower doses. It's an unfortunate problem that I run into, not too infrequently, unfortunately. With tirzepatide, it's a somewhat similar situation. So monthly, we increase from 2.5 to 5 the next month, then usually to 7.5, 10, 12.5, and 15. Now, we don't have to go all the way up with tirzepatide. It's nice that the insurance should allow the 5 milligram dose, 10 milligram, or 15 milligram dose ongoing. They'll often push you to get off of the intermediate, the 0.5 milligram doses, but it's nice that usually we can rest at a pretty low dose here at 5 milligrams or increase to the higher doses if needed. So that gets to that second question. So a second generation anti-obesity medication was initiated in your patient 2 weeks ago, and the patient comes back to you reporting that they've been experiencing gastrointestinal issues. Which of the following is the best way to manage these fairly common side effects? Stop the GLP-1 or the tirzepatide or the semaglutide and instead switch to glimepiride, or B, titrate the dose more slowly, or C, switch to PO, oral semaglutide, or D, change to a shorter acting agent. Now, the answers were all over the place in the pretest. Let's see what you think now that we're reviewing it again. And I see here we have titrating the dose more slowly, and that's exactly right. We certainly don't want to switch away from these effective medications to a sulfonylurea that likely is not going to be nearly as effective and may have other problems. There's no reason to switch to oral semaglutide. That usually doesn't lead to nearly as much weight loss. It usually doesn't lead to nearly as much improvement in glycemic control, and it tends to be more poorly tolerated in terms of gastrointestinal side effects. And then there's no reason to change to a shorter acting agent. Rather, just titrating more slowly and using some of the other strategies I gave you is hopefully going to be sufficient to help this patient. So then when we follow up the patient over time, so here we have the baseline that we reviewed before. At 6-month follow-up, he's doing great. His glucose has all but normalized. His A1C is now at target. His blood pressure has almost normalized and significantly improved. He's lost almost 30 pounds. His waist circumference has increased very impressively. So he's in a much better place. And then 6 months later, we see even better outcomes. So his A1C is now almost perfect. His blood pressure is perfect. His lipids are perfect. BMI is now out of the obesity range. Waist circumference is much improved, as can you see the liver test there. So this is the outcome that I see with patients Often, not always. Some people don't get a benefit of these medications. Some people don't tolerate the medications, and we have to stop them. And other patients, they get some benefit, but not nearly as good as Mr. J. But a lot of people do get really, really amazing benefits like this. And hopefully so many of our patients going forward will get similar benefits as well. So from there, I just want to hit home the point that obesity is a chronic condition. We should educate patients as such that this is a chronic long-term management condition. Um, Obesity is driven by genetics and environment, and we shouldn't admonish people about having more willpower. We all need willpower for anything, you, me, and everyone else. But just telling people to suck it up and try harder is not good enough. We're not doing our job if we just do that when it comes to weight management. And medications can be very effective to transiently change physiology, leading to improvements in weight and weight-related comorbidities, but only while taking them. Some people will lose all the benefits of the medication if the medication is stopped. Other people will lose a lot of the benefits. Some people will be able to do great long-term, even if the medication is stopped, but that's few and far between. These medications are approved and indicated for long-term use. And we should counsel our patients and remind our patients that managing obesity will be lifelong, just like with other chronic diseases. And that leads into the third of our questions. So to facilitate shared decision-making, what counseling and education points would you provide a patient regarding second-generation AOMs, allowing them to make informed decisions about their therapy? Is it A, GI adverse events are mild, but they don't typically go away, so that's going to be concerning. Or they can take only a second-generation AOM for just 3 months, or obesity is a chronic disease, and this therapy will help adjust physiology while taking it, or you don't have to worry about your diet with these therapies, as they just magically work, and the weight just comes off without even trying. And here, you're right on with the answers here. Obesity is a chronic disease. This therapy will help adjust physiology while taking it. In fact, we do need to attend to diet and exercise and our health behaviors. The medicines, if they work well, will make it easier, but they're not magic. They don't just make the weight magically come off. So with that, we covered the key parts that I wanted to cover today. And I'm going to stop sharing my screen, and if you have any questions, we have time for that. So any questions, of course, you can also send your questions later on. And hopefully you'll be joining us next week for the in-person event, and we'll have lots of opportunity for discussion and questions and putting our heads together on what's on your minds. And so if there's no questions, I'm going to turn it back to Kristen. Thank you all very much.
Hi, thank you. I was trying to type it into chat, but you beat me. Somebody's asking about the availability of these medicines. Does any idea if they'll become more available?
Yes, they will absolutely become more available. And when that is, I have absolutely no idea. Nobody does. The talk on the street is that in the near term, they're going to continue to be exceedingly difficult to get. The tirzepatides, all the doses are really challenging to get, at least in my area, in the DC area. The semaglutide, high dose semaglutide, has been quite available. The problem is the low and mid doses are not well available. And so it's really hard to get people on them because I would absolutely not start people at the higher doses without titrating. So there's just so many people that we can't use these medications just yet because the availability is such a challenge. Again, that's not always going to be the issue. Luckily, we have a range of medications, so we use a lot of medications outside of these when we can't get them. And I would expect, in the near future, the medications will be much more available. I just don't know if that's going to be 3 to 6 months or 9 to 12 months or longer or not. But long term, you'll be able to get them. We just don't know when that's going to be. I would keep trying to get them, but you're just going to have to work with your patients as best as possible with the limitations right now.
All right, so just another quick couple of seconds to put something in the chat if you have a question. Great. Oh, and thank you. Okay, so this is for CE. So if you want to claim your credits, please scan this code, or you can visit the link on the screen to get your credits. Dr. Kahan, this was a fantastic presentation. Thank you so much. I'm really looking forward to meeting you next week at the live event in Washington, D.C. on May 21st. Maybe if we can leave this up, but thank you all so much, and we'll see you next week.